Good morning, one and all. Good morning, one and all. So today we are starting the second class of session 7 by Dr. Manu Krishnan, Assistant Professor, Department of Anatomy, Sharada Ayurvedic Medical College, Mangaluru, Karnataka. Before the session starts, I'd call Ms. Ritika Kapoor to deliver the prayer.
नमामि धन्वन्त्रि आदिदेवं सुरासुरे वन्दितं पादपादनं लोके जरारुके भया मृत्युनाशं दधारिषं विविध औषधीना धन्वन्त्री प्रमानाथं सर्वरोगे निवारितम् आयुर्वेद प्रवक्तारं वन्दे पीयूषं धाय सर्वे जना सुखिनो भवन्तु सर्वे सन्तु निरामया ॐ शान्तिः शान्तिः शान्तिः
Thank you, Ms. Ritika. So, sir, the platform is all yours. You can continue, sir.
Thank you, sir. Good morning, everyone. So, we have discussed about the basic classification of joints in the last class, right? We have seen how the joints are grossly classified, and we have seen the further categorization of the joints, and we have seen the different types of joints. So today we'll be discussing about a particular joint, that is the shoulder joint, which is very important in your clinical practice, as the shoulder joint is the most unstable joint, and commonly the case will come to you with a shoulder dislocation or something like that. So you should know the proper joint anatomy for the proper practice. Okay, so let's begin with our session today. So the shoulder joint is a synovial variety of ball and socket joint. And we have seen the different types of synovial joints yesterday. In that, the last one was the ball and socket joint, which has got some peculiar features. It is having a very higher degree of mobility, and that is formed between the head of the humerus and the glenoid cavity of scapula. So you'll be knowing about the shoulder joint. There are two bones, the humerus, the upper end of humerus, and the lateral angle of the scapula will be joining each other. And that union or articulation of the glenohumeral joint is formed by the head of the humerus and the glenoid cavity of scapula. And it is the most mobile joint and the least stable joint. So this is an important thing to remember. It's the most mobile joint and it is the least stable as well. So here we have a representation of the shoulder joint. So I'll be just briefing about the basic parts of the shoulder joint. So here we can see the head of the humerus, which is covered by a thin layer of hyaline cartilage or the articular cartilage. So previously we have discussed what are the basic components of the synovial joint. There was an articular cartilage on either sides. So this one is the head of the humerus. And here you have the glenoid cavity covered by a thin layer of articular cartilage. So this is the basic articulation happening in the shoulder joint. And over that, you can see from the margins of the glenoid cavity, from the margin here, you can see a part that is coming over here, and that is nothing but the capsule of the shoulder joint. We have heard about the capsular ligament yesterday. So this is the articular capsule above and below. So the further structures we'll be discussing through the slides. So the articulations of the shoulder joints, that should be the first heading when you're writing down the exam. And the articulations are the head of the humerus and the glenoid cavity, which is deepened slightly and effectively by a fibrocartilaginous ring called as glenoidal labrum. So what you can see here is a coronal section, like a transverse section through the shoulder joint. This is the glenoid cavity here. And this is the head of the humerus here. So in the tip of this glenoid cavity, you can see two projections. So that is a round fibrous cartilaginous ring that is called as the glenoid labrum. And the ligaments, you can see the ligaments which support the shoulder joint are, the first one is the capsular ligament. And that capsular ligament is nothing but a thin fibrous layer of joint capsule which surrounds the glenohumeral joints. And medially, it is attached to the margins of the glenoid cavity, while laterally to the anatomical neck of the humerus. And in the inferior part, there is a slight difference, and it extends downwards 1.5 centimeters or more onto the surgical neck of the humerus. So while you have studied the osteology of humerus, there is an anatomical neck and there is a surgical neck. So that I'll revise it once the initial part is over. So that time I'll show you how the attachments are made. Then the second ligament is the glenohumeral ligament. These are nothing but three thickenings in the anterior part of the fibrous capsule. So here you can see the thickening of the fibrous capsule here, which is again further classified into three: the superior, middle, and inferior glenohumeral ligaments. So the upper thickening here you can see that is the superior glenohumeral ligament. This is the middle glenohumeral ligament, and this is the inferior glenohumeral ligament. So all these ligaments, as I have told you yesterday, the joints are supported by a group of soft tissues, and in which ligaments play an important role because it supports the joints and it stabilizes the joints. So here we have the superior glenohumeral ligament, middle glenohumeral ligament, and the inferior glenohumeral ligament. So these are the ligaments. The next ligament which supports the shoulder joint is the Coracoacromial Ligament. So the name suggests the Coracoacromial Ligament is a strong band of fibrous tissue which connects between the base of the coracoid process of scapula to the anterior aspect of the greater tubercle of the humerus. So you know these both structures. In the scapula there is coracoid process. It's one among the three processes: the coracoid process, acromial process, and the spinous process. The coracoid process, from the base of the coracoid process, a ligament arises, and that will be attached to the anterior aspect of the greater tubercle of the humerus. And there is a third ligament, that is the transverse humeral ligament. So the transverse humeral ligament is nothing but a ligament that bridges between the two ridges of the bicipital groove. So the bicipital groove is the bicipital groove, or the intertubercular sulcus, is through which the long head of biceps brachii muscle is passing through. So over that particular tendon, there is a bridge of ligament formed above it, and that bridge is termed as the transverse humeral ligament. And there are a few accessory ligaments for the shoulder joint. The first one is the Coracoacromial Ligament. As the name suggests, it extends between the coracoid process and the acromial process. It's very easy to remember. That will be shown in the further slides. And the coracoacromial ligament extends between the tip of the coracoid process and the acromial process. and it gives protection to the superior aspect of the shoulder joint. And the coracoacromial arch, and that is an important term to remember. The coracoacromial arch makes a secondary socket for the shoulder joint. As you already know, in the ball and socket joint, the socket is made by the glenoid cavity and the glenoid labrum. But there is a secondary socket mechanism in the shoulder joint which stabilizes the joint and supports and protects the joint. And that secondary socket is made by an arch formed by the coracoid process, acromion process, and the coracoacromial ligament between them. So we will see that in the following slides. And the bursae related to the shoulder. What do you mean by bursae? In the last class, while explaining the synovial joints, I have told you about the synovial membrane and the synovial fluid and the synovial fluid filled sacs. And that sacs are termed as the bursae. And according to the shoulder joint, there are a few bursae which supports and which gives protection to the joint. The first one is subscapular bursa. So from the term itself, sub means below and scapular bursa. So the subscapularis muscle you might be knowing, right? So the bursae or the synovial sac which lies between the tendon of the subscapularis and the neck of the scapula is termed as the subscapular bursa. The next one is the subacromial bursa. So you already know about the acromion process. So just beneath the acromion process, there is a bursa called as the subacromial bursa, which is otherwise known as subdeltoid bursa. As we all know, the deltoid muscle covers the shoulder joint like that. To some extent, it is covered by the deltoid muscle. That's why it has got the name subdeltoid bursa. And the next one is the infraspinatus bursa. So the infraspinatus muscle arises from the infraspinous fossa of scapula, and that will be attached to the humerus. So the infraspinatus bursa lies between the tendon of infraspinatus and the posterolateral aspect of the joint capsule. So that you can just imagine the three-dimensional view of the shoulder joint, where the infraspinatus muscle is getting attached to the humerus, and below the tendon of the infraspinatus on the posterolateral aspect of the joint capsule, you can see a small synovial sac, that is the infraspinatus bursa. So here we have the representation of the bursa. So you can see this is the acromion process. This is the coracoid process. And between the coracoid process and the acromion process, you can see a ligament, which is the dark colored part. That is the Coracoacromial Ligament. So these three structures, the coracoid process, the Coracoacromial Ligament, and the acromion process, forms the Coracoacromial arch. So this arch acts as the secondary socket for the shoulder joint. And immediately below the acromion process, this area, you can see a balloon-like structure that is nothing but a sac of synovial fluid. Here it is called as the subacromial bursa. And there will be a slight extension of that sheath as a sheath to the tendon of biceps, the long tendon of biceps. And bridging above the tendon of the long head of biceps, you can see there is a bridging ligament, and that is termed as the transverse humeral ligament that we have discussed earlier. And here, in this lesser tubercle, there will be attachment of the subscapularis muscle. So immediately below that, we have removed the muscle from the picture here. So below the muscle, you can see the subscapular bursa. So we have seen two bursa here, the subacromial bursa and the subscapular bursa. The infraspinatus bursa, now it can't be shown here in this diagram, in this aspect. So we'll discuss that later. Next comes the arterial supply of the shoulder joint. So the arterial supply, you'll be knowing like the major artery which supplies the upper limb is the brachial artery. So the brachial artery will give off certain branches, that is the anterior and posterior circumflex humeral artery, then the subscapular artery, and the suprascapular artery is a branch from the thyrocervical trunk. So these are the three arteries which supplies the shoulder joint. So if you have studied the axillary artery and if you have studied the brachial artery in detail, you will be remembering all the branches, and just imagine how the circumflex arteries will be like encircling the neck of the humerus. So that defines the arterial supply of the shoulder joint. And the nerve supply of shoulder joint, it is supplied by the axillary nerve, the suprascapular nerve, and the musculocutaneous nerve. And all these are branches from the brachial plexus. So you can see the branches from the brachial plexus supplies the shoulder joint, and they are specifically the axillary nerve, suprascapular nerve, and the musculocutaneous nerve. So let's have a revision. Let's have a revision regarding the same things what we have studied now. So I'm just drawing a simple diagram here. I'm representing the bones with the blue color. So here I'm drawing the glenoid cavity. Excuse me. This is the glenoid cavity here. And here we have the head of the humerus. And here we have the bicipital groove. And here we have the anatomical neck. And here the surgical neck. So these are the bony structures. And above this, I'm just drawing here I'm drawing the acromial process here. And here we have the Coraco process. So this is the diagrammatic representation. And I'm adding the capsular ligament to it. So the capsular ligament extends between the margin of the glenoid cavity and it reaches till here. That is the anatomical neck here. So superiorly it is like that. And inferiorly there was a difference. The capsular ligament was going little down and it was getting attached to the surgical neck. So there is a recess you can find here. This is a recess over here. And this is the capsular ligament. And these two surfaces are covered by an articular cartilage. So the yellow color represents the articular cartilage. And there will be a fluid that is filled within this space, and that is nothing but the synovial fluid. So this represents the basic structures, and we will add up the bursa to it. So I'm representing the bursa with the yellow color itself. So as I have told you before, there is one subacromial bursa here, just below the acromial process and above the capsular ligament here. And here will be the lesser tubercle, and here will be the greater tubercle. So the subscapular muscle will be here. I'm not drawing it now. So there will be the subscapular bursa, as we have seen in the previous picture. And I've told you about the deltoid muscle, right? So the deltoid muscle arises from the lateral border of the acromial process. So from here, I'm drawing the deltoid muscle here. So the deltoid muscle will be going like this. And it provides a support for the shoulder joint. And you can see the subacromial bursa is extending little down till here. And that's why it has got the name subdeltoid bursa. So it is called as subacromial bursa or the subdeltoid bursa. And I'll be drawing another ligament here. There was one transverse humeral ligament which bridges the bicipital groove. And we have another ligament here, connects between the coracoid process and the acromial process. That is the Coracoacromial ligament. So here, the coracoacromial ligament, the acromial process, coracoacromial ligament, and the tip of the coracoid process, it forms a secondary arch, coracoacromial arch. So this defines the basic structure of the shoulder joint. So you can draw the diagrams like as I've shared in the previous slides. So this was just a revision to know how the structure will be scribbled down. So let's continue with the previous class. So we have revised through the structure of the shoulder joint. So now we'll be going with the next part, that is nothing but the movements of the shoulder joint. The shoulder joint is a highly mobile joint. I have told you, it's the most mobile joint in the body and the most unstable one as well. So the movements of the shoulder joint includes the flexion and extension, then the abduction and adduction, the medial and lateral rotation, and circumduction. So the same thing, I have a diagrammatic representation here. So the flexion of the shoulder joint, if you just draw your arm forward, that is the flexion of the shoulder joint. If you draw it backwards, that is the extension of the shoulder joint. Then you have the abduction and adduction, where the abduction of shoulder joint will draw the arm away from the body, that is the abduction. And if the arm is drawn close to the body, it is adduction. So you can remember the term by like thinking the first part. The abduction means the kidnapping or taking away something from your side. So your arm is moving away from your body. So that is abduction. And adduction, as the first three letters add, it will add up to the body or it comes close to the body. So you can remember the adduction. And the medial rotation and lateral rotation, it's little complicated. You just have to flex your elbows and with the arm in the supine, like the palm in the supine position. And you have to just move the arm away from the body, that is lateral rotation, and then towards the body, that is the medial rotation. And the most mobile part of the shoulder joint is, it is capable of doing the circumduction. So it's a combination of all these movements. There will be slight extension, there will be abduction, there will be flexion, and there will be a slight adduction as well. So that rotatory movement have been diagrammatically represented here. So you can just name them, and if possible, you can scribble down these diagrams as well in a simple manner. So this defines the movements of the shoulder joint. So the only part like remaining is how if it's being a highly unstable joint, how it is stabilized. So it is a very unstable joint as I've told you. So there are some factors which maintains or provides stability to the shoulder joint. So the first thing you have to remember is the rotator cuff muscles. There is a group of 4 muscles which are attached to the lesser tubercle and the greater tubercle in a particular manner so that it forms a cuff around the upper part of the shoulder joint. And that rotator cuff is formed by the 4 muscles, teres minor, infraspinatus, supraspinatus, and the subscapularis. So altogether it forms a musculo-tendinous cuff around the shoulder joint and stabilizes it. And the second one is the coracoacromial arch or the secondary socket. As I have told you earlier, the coracoacromial arch is formed by the coracoid process, the coracoacromial ligament, and the acromial process. Then we have the long head of biceps brachii. The biceps brachii muscle is having 2 heads, the short head and the long head. And the long head will be going through the bicipital groove, and it is kept in place by a transverse humeral ligament which bridges the bicipital groove, and it turns over the shoulder joint and finally get attached to the supraglenoid tubercle. So you might have studied about the osteology of scapula, where you have studied the infraglenoid tubercle and the supraglenoid tubercle. So the biceps tendon is, the long head of biceps tendon is attached to the supraglenoid tubercle. That also stabilizes the joint superior. And we have another structure called as the glenoid labrum. That is nothing but a fibrocartilaginous ring around the glenoid cavity, making it little more deeper, so that the socket will be deepened by the fibrocartilaginous ring on the periphery. And that also have an action on the stabilization of the shoulder joint. So these are the 4 factors that you should remember regarding the factors providing the stability of shoulder joint. So we have discussed the basic anatomy of shoulder joint. We have seen the arterial supply, nerve supply. We have seen the movements of the shoulder joint. And now we have seen how the stability of the shoulder joint is maintained. And the next part is the radiological anatomy. Here we have a representation of the normal anatomy of radiological anatomy of the shoulder joint. So here you can see the glenoid cavity and the head of the humerus. Here you have the anatomical neck. Here we have the surgical neck. And above that you can see the acromial process. And here you can see the tip of the coracoid process. Then these are the things that you should remember regarding the shoulder joint. And you can see the superior border of scapula as well. Then the clavicle is visible. So when you are practicing as a clinician, that time if a X-ray comes, you should first know the normalcy, then only you can identify the abnormalcy of that particular X-ray that you will be studying in detail in the final year in Shalyatantra. So I'm just giving you an outlook about how it will be. Like you might be curious about how you can differentiate the dislocation. Okay, so for that purpose, I'm just giving you the basic radiology idea here. So this defines the basic radiological structure of or radiological view of the shoulder joint. And here, these are the causes of the restricted shoulder movement. So you can write it as the applied anatomy or the clinical anatomy of the shoulder joint. So these are the common things that affect the movement of the shoulder joint. So the first one is the frozen shoulder, or it is otherwise known as adhesive capsulitis, that you will be learning later. So just try to remember these names so that you can quote some examples. And if you are curious, you can just Google it or you can read more about these conditions. Okay. And the second one is the rotator cuff tendinopathy. I've told you what is rotator cuff. It's a group of a musculotendinous cuff formed by 4 muscles. So if there is any inflammation or any damage to these rotator cuff muscles, there will be like difficulties in the proper movement of the shoulder joint. Then we have another condition called the impingement, where it has been represented here in the diagram. You can see this is called the subacromial bursitis. The subacromial bursa, sometimes it will get inflamed. So if it gets inflamed means you won't be able to abduct the arm. If you abduct the arm, there will be sudden pricking pain over that particular region. And that is the subacromial bursitis. Then the rotator cuff muscles, if any injuries happen to it, that will restrict the movements of the shoulder joint. Then we have osteoarthritis. It is a condition, what I have mentioned in the previous class during explaining the synovial joints. If the synovial joints are affected by any autoimmune diseases or like degenerative changes are happening there, so that will cause the inflammation of the joint. So that is another case. And the most common case that is affecting the shoulder joint is the dislocation. So being a highly unstable joint, the dislocation is very common in case of the shoulder joint. So let's see how the dislocation happens. So this is the diagram showing a shoulder dislocation, where you can see there is a sudden dip from here. You can see the normal shoulder here, which is having a curvature by the deltoid muscle. So once dislocated, you can see there is a flattening of this curve here. And you can see the acromial process here. So below that, you can see the deltoid is flattened up. So that is a typical sign to know the dislocation. And on the further studies, we'll just suggest him for an X-ray. So the normal X-ray, as I've told you earlier, consists of these structures. There is the glenoid cavity, there is the head of the humerus, the acromion process, then the coracoid process, the clavicle. So this is the basic structure of the shoulder joint. And when we take an X-ray of the dislocated joint, you can clearly see here, the glenoid cavity is here, but the head of the humerus, which is supposed to be here, is shifted anteriorly. So what you can see here is the dislocation of the shoulder joint. So if you know the proper anatomy and if you know the normal X-ray, then you can identify there is a dislocation of shoulder joint. So these are the facts that you should remember regarding the shoulder joint. So I hope you got a clear idea about the structures involved in the shoulder joint and what are the arterial supply, what are the nerve supply, and how the movements are made possible in the shoulder joint and how they are classified, and the clinical anatomy as well. So if you have any doubts regarding the class that have been completed, you can ask the queries.
Platform is open for discussion. So if you're having any doubt, kindly put that in the chat box or you can directly ask him. Sir, actually, I got a message.
Okay, sir.
Sir, can you explain rotatory cuff muscles once more?
Yeah, sure. So I'll do one thing. I've told you regarding the rotator cuff muscles, right? So the rotator cuff, I'll be just briefing it on the white screen. So you'll have a clear idea about how they are formed. So I'm just going to draw the rotator cuff muscles here. So before that, as the same representation, the blue color represents the bone. So I'm just drawing the upper end of humerus here.
Excuse me, sir. Sorry for interrupting.
Sorry.
The screen is vertical and...
Okay.
Yeah, now it's fine, sir. Thank you.
One second. So I'm taking a sagittal section through the shoulder joint here. So you can see the shoulder joint I'm drawing here. Just imagine this is the lateral view of the upper end of the humerus. So I'm just drawing how the rotator cuff muscles will be attaching to it. So this is the anterior part and this is the posterior part. And you can see there are 4 structures. So here we have the lesser tubercle and the greater tubercle. I can't show it right now. So I'm just representing the rotator cuff with some circles. So the red color I've changed, and here you can see the first one beginning from the posterior part. The first one is the teres minor muscle. Second one is the infraspinatus. Then we have the supraspinatus. And we have the subscapularis muscle here. So you can remember it by the terms T represents the teres minor, I represents the infraspinatus, S represents the supraspinatus, and S representing the subscapularis. So from posterior to anterior, starting from the greater tubercle to the lesser tubercle. So I'm just showing the greater tubercle here. Imagine this is the greater tubercle. It has got 3 parts. There are 3 impressions on the greater tubercle here. So one here, the second one here, and the third one here. So on the lowermost impression, there is attachment of the teres minor. And in the middle impression, we have the attachment of the infraspinatus. And in the upper impression of the greater tubercle, we have the supraspinatus. Then on the lesser tubercle here, we have the attachment of the subscapularis muscle. So always remember, the rotator cuff muscles can be remembered by the term TIS. So the term TIS stands for the muscles of the rotator cuff, the T for teres minor, I for infraspinatus, S for the supraspinatus, and the final S for the subscapularis. So these are the rotator cuff muscles which forms a complete musculo-tendinous curve around the superior aspect of the shoulder joint and stabilizes it. So this defines the rotator cuff. And if you have any further queries, you can ask me.
Sir, two questions came chat box.
Okay.
Sir, can you repeat the articulation of shoulder joint once more through that drawing?
Sure. No problem.
I hope you're comfortable with that.
Yeah, no problem.
Okay.
Okay. So we are just starting with the brief introduction with that complete anatomy of the shoulder joint. I'll start with part by part. So initially we have described the articulations. So the articulation is the most important part of a joint. So when two bones are articulating, that is defined as a joint. So let's begin with the parts that are articulating here in the shoulder joint. So first we have the glenoid cavity here, and I'm drawing a part of the scapula here so that you can easily describe this. Then the second one, that is the head of the humerus. Is the head of the humerus, and we have the greater tubercle here, the lesser tubercle here, and in between that we have the bicipital groove. So the bicipital groove is which allows the movement of the long head of tendon of biceps. So here we have the tendon of biceps. So just that red color represents the long tendon of biceps. And these are the articulating surfaces here. The glenoid cavity of the scapula, then the head of the humerus, and they are covered by a thin layer of the articular cartilage. Then the structures which are connecting it. So initially we have described the articulating surfaces. Now we can add up single structures to it. So here we have the acromial process, and here we have the coracoid process which is attached to the scapula, and I'm drawing the ligaments right now. Between the coracoid process and the acromial process there is Coracoacromial Ligament. Then over the long tendon of biceps here, just the ligament that bridges between the bicipital groove, we have the transverse humeral ligament, since it is transverse. Here you have the horizontal fibers, and that is the transverse humeral ligament. Then you know about the margins of the glenoid cavity. So starting from the margin of glenoid cavity, excuse me, one second. So from here, I'm just drawing the glenoid cavity once again. So from here, from the upper margin of the glenoid cavity, we have the capsular ligament. And from the lower margin, it hangs a bit downwards. That is what we have discussed, about 1.5 centimeters below the inferior part, and it gets attached to the surgical neck of the humerus. So this defines a capsular ligament. And after that, you can see These are the capsular ligament, transverse humeral ligament, and the coracoacromial ligament here. And the further parts, like the deltoid muscle, I'm adding up here. So here I'm just drawing the deltoid muscle, which is arising from the lateral border of the acromial process. So this is the deltoid muscle here. And we'll add up the bursa to it. Below the acromial process and slightly extending towards the deltoid, you can see the subacromial bursa. So this one over here is the subacromial bursa. So the subacromial bursa or the subdeltoid bursa, it acts as a cushion. And in the clinical anatomy, we have told if any inflammation happens to this particular bursa, that will cause pain while abducting the arm. So this defines the articular surfaces and the major ligaments which support the shoulder joint. Along with that, I'm just showing the thickenings of the capsular ligament. There was superior glenohumeral ligament, there was middle glenohumeral ligament, and there was an inferior thickening, that is an inferior glenohumeral ligament. So these will add up to the stability of the shoulder joint. I hope the idea is clear for you. And if you have any further queries, you can ask.
If you're having any further doubts, you can kindly ask. So can you repeat the arterial supply once more?
Yeah, sure. So the same thing I'll be explaining with the diagram so that you can have a clear idea about that. So here I'm just drawing the, head of the humerus. And the arterial supply is supplied by 3 arteries mainly. The first one that you have to always remember is the branches that are arising from the brachial artery. So I'm drawing the 2 arteries here. So consider this one as a brachial artery. And there will be 2 branches. There will be an anterior circumflex humeral, and there will be a posterior circumflex humeral artery that will be surrounding the shoulder joint or the neck of the humerus. And that same arteries, there will be small branches supplying the entire shoulder joint. And along with that, there is subscapular artery, that is another branch from the brachial artery. And one more artery is there, that is the suprascapular artery, that is arising from the cervical, like a thyrocervical trunk, and that will also supply the shoulder joint. So the main 3 arteries are the suprascapular, then the subscapular, and the anterior and posterior, or the posterior, you can say the posterior circumflex humeral artery. So these are the arteries which supply the shoulder joint. Any further queries?
Any other doubts?
So I hope the shoulder joint is clear for you. And if you have any further queries, you can ask me. Otherwise, we can go to the discussions.
Sir, I hope there are no further queries, I think.
Okay, sir.
So we are very thankful, Dr. Manu, on behalf of Department of Anatomy and also Shiva Ayurvedic Medical College. We'll always be thankful, and we should really appreciate, because the simple way of taking class, and it was really fantastic. It was informative, and the most appreciable thing is actually the simplicity of taking class, and it was. I hope you conveyed the thing to our students, and they understood everything. Thank you so much, sir. Thank you so much for accepting the invitation with a happy mind. I hope you had 2 wonderful days with us.
You say. And I would like to thank Dr. Anup sir for giving me such an opportunity to take the class, and I've been happy to present in front of you people. So if you have any further queries, you can contact me through Dr. Anup sir. So thank you once again.
With your permission, I'm just winding up the session.
Thank you, sir. No problem.
Okay, sir. Thank you.
Thank you.